I just want to introduce myself, I guess. I'm going to try to record a video where I talk about the fourth edition of the ASAM. I don't know how this will go. I've got some background music on, so we'll just kind of play around with this as I discuss the ASAM. I use this form that's free to download. It's actually sent to me through work, and I didn't realize you could download it free, but you can use it in Adobe. It's a PDF, and then you can do some different things to kind of print it when you finish up. I usually like to trim it down. The ASAM has some general instructions here, but I just want to say hello to everyone. This is the first time I've made such a video. I thought it might be useful for coworkers and supervisees, so we'll see what it goes. My name is Jason D. Wayne King. I have a Master's of Arts in Clinical Psychology, and I have a LCADC in the state of Kentucky, and I'm approved for supervision, which means I'm an independently licensed substance use counselor in the state of Kentucky. Today I just want to walk everybody through the ASAM criteria 4th edition, the level of care assessment guide, and that's what this form is. I get dry mouth really bad, and I have some allergies, so my breathing's weird. I hope the music don't just die out on us. Seems like it has now. It's trying to load. I got a playlist. I'm hoping that'll help with some of the weirdness in my voice and whatnot. But this is a free guide from ASAM. It's one of the most practical tools we have for determining someone's appropriate level of care. I use this in an outpatient setting, but I have also used it in a inpatient rehabilitation setting, and I use it for IOP groups. Now, it kind of does help me too as we go through this. You'll see what I'm talking about. It kind of helps me determine whether or not a person is appropriate for outpatient care. That's what I'm focused on. I'm focused on seeing people outpatient. So this video is going to be for counselors, case managers, behavioral health providers. Watching how I go through this as a clinician can help you kind of understand what materials and stuff that you can garner if you read my ASAM. It's really for just a placement and to help kind of back up what I'm going to do clinically in the next steps. Medicaid in the state of Kentucky wants you to have this ASAM criteria done so you can back up what you put on your treatment plan, back up your diagnosis, and back up how you're setting up a person's treatment. So I'm making this video for free to sort of walk you through what I do. So anybody wants to garner something from this, then have at it. Now, the ASAM, it has a lot of instructions. I do encourage you to read all of this stuff. I read through it. I'm not going to read through it in this video. I'm just going to get to the meat of it. There's a lot of other videos I found on YouTube that will walk you through how they developed the ASAM, how you can use it, and how they came to all the conclusions, and yada yada yada. I'm not going to do that. This is going to be more of a what to do. So all that explains it, and it's great material. Please read it. So this is where I always start, and I like to use this little click type text thing, and we'll make up a client. Shoot, I'm going to look at things on my desk here. We're going to put Coke peppermint, because I got that oil for a diffuser, so and a Coke Zero. So Coke peppermint's our client, and I'm going to put my name here. I always find it odd to type it out this way because I'm used to typing my credentials. My OCD here, I like to get those things. This is my only downfall with it. When you try to click, you end up clicking more text box, and it's a little bit counterintuitive, I guess, to get everything just peachy keen. You type the date here. If you're like me and have a background in federal work, you type your dates like that. But type your date in there, and then that's handy to know. And then type your credentials. C-A-D-C. There we go. I like to type mine like so. And you just type that in there like that. Now, for me, I'm a mental health or a substance use disorder counselor. And that's what it's counted as here. So, oh no, this one don't. Huh. The one I got at work, it lets you click the little boxes. So we'll just type an X in there and that's fine. The ASAM you can do via telehealth. I don't recommend doing it audio only, simply because that is just, you can do it that way if you have to, I suppose. Telehealth is better if you've got both audio and video. In person is the best, and that's how I like to do them. But whatever you choose to do, you're just going to put you a mark there so you know. I'm not a medical and physical health professional. I'm not a nurse, physician, or advanced APRN or any of that stuff. I'm not any of those things. But you see here it says seek behavioral health consultation as needed. So if you are of that credential, reach out to whoever you're working with for this. Now, the first thing on the ASAM in this new criteria is to get blood pressure, heart rate, temperature, respiratory rate, and pulse ox. If you don't have a pulse oximeter, the biggest thing you kind of want to look at, if you can, is blood pressure. Now, if you are unable to measure, then you're going to click this little box here. But if you do, always type client stated that they see I put PCP because most people knows that means primary care physician, or you can say a doctor for blood pressure needs, or you can type something like client stated they have no health concerns, or whatever it may be. But the point is what we're looking for in this immediate thing right out of the gate. A lot of the drugs that people would be abusing and have some trouble with are things like stimulants or opioids, and as they are either using them or coming off of them, their blood pressure can spike, and that's what we want to kind of look at. Do we need to make a referral to a doctor right out of the gate to get them medically stable? And this little measure for blood pressure could be what we need to know. But you're just going to type it. It's really hard to type it in here, but 120/80 is the go. You see how that kind of looks? That looks bad, right? Can't hardly read that. Well, you can click here and make it a little smaller, and it'll fit in there. Now, I still don't like that myself, but that's technically correct. If you don't like how that fits in there, you can also do something like that right there, I guess. It's just that you record it, and that's what we're looking for. You can get there. We'll say they got 83 beats per minute, whatever. If you can't get this other stuff, then you just click that and whatnot. Now, this is the referral reason. So what brings the client in? And you want to probe a little bit. I try to be super diplomatic. If it's a drug court client, I might say, so I see you were offered drug court while you were incarcerated. What made you decide to take that as opposed to serving out your sentence? 99% of the time, the answer to that's going to be, I'd rather be in treatment than in jail. And that's when you want to use your diplomatic skills here to try to encourage them to participate in therapy, and use that right out of the gate to set your therapeutic alliance up with the client. But it could be any reason. They may say something like, I need to make changes in my life before my family leaves me. And, that's a real reason. If you put something like that on there, I always like to do quotes. And that's real right there. That's some of the reasons I've actually had people tell me something very similar to that. If it's drug court, you might put client is referred to an IOP group, intensive outpatient, through a district court. Or you might type client is referred by Kentucky Specialty Courts. That would be drug court. Whatever, oh, sorry, I'm getting a message here. I'm going to close that out while I record here. Whatever the reason being, you just want to type a little something here so whoever reads your ASAM can see why they came in. People do come in for outpatient treatment without needing a court thing too. That's just an example. That's just an example, and you just want something that when your reader of your ASAM reads this, they can say, oh, okay, that's why they're here and that's why they're seeking therapy now, because it's not normal in the drug culture to just one day just up and say, oh, okay, I'm going to go get treatment now, I'm going to go make meaningful change. Usually there's something that kind of bumps them toward it. So that just kind of helps set it up. Now, we want to ask this question: do you have any physical health issues that feel like an emergency? And that's worded kind of odd. But if you ask it straightforward and blunt like that, you might get sort of a cross-eyed, side-eyed sort of look, but you're going to follow up with that and explain. You're like, well, I'm talking about your blood pressure. We checked that and it was a little high earlier, or it was a little low earlier. Does your blood pressure bottom out like that? Does your sugar bottom out? Have you been eating right? Do you feel kind of off? Do you feel kind of strange? Do we need to send you to the hospital? And would you go if we did send you? And kind of just check on them right there. That's what we're looking for. So if yes, then you would type it there and maybe try to get them to the hospital if that's the case. If no, and they're good to treatment, you're just going to put you an X there, or a check. I like the other one I got at work where it lets me check the boxes. Are you concerned that you may have withdrawal symptoms severe enough to need care in a hospital? Now, if you ask every person that comes in that question like that very bluntly, they're always going to say no. But what we're looking for, and you might want to tease a little bit during your intake process before you even start your ASAM, and try to tease that information out of them. If it's alcohol or benzo, that's what we're looking at. Something like methamphetamine, they're going to be extremely tired for 3 or 4 days, but they're certainly not going to completely crash out to the point where it's a health risk. They might sleep 3 days if they stay in withdrawal, but they're no major risk. And you can kind of gauge this yourself and ask the question, do I think they are at risk? If you kind of look at a person, you say, okay, they had a relatively normal blood pressure, they're agreeing to go see a doctor, they've been out of jail or whatever for 3 weeks now, and they seem just fine, and they tell you no, they don't think that you don't think they're in withdrawals, they don't think they're in withdrawals, or no, they've been withdrawing for a while, or they've done this before and they didn't have any serious health complications, and it's not benzo and not alcohol, and you're not worried about DTs and you're not worried about seizures and stuff, then you go ahead and click no. Now, I highly recommend in this section right here, this little green key section, if there's something that you think is risky, and even if they said no, you're going to type up a summary down here. We'll get to that here momentarily. And this is if you've ever been treated in a hospital for withdrawal. Maybe this is a no too. It's just a straightforward question. Have you ever had, and you'll want to follow up and discuss with them. Now, this little section here asks you, after you've asked them their questions, while you've got them in there, do you seem to have physical health symptoms, including withdrawal, that might need hospital care? A lot of times, self-care is thrown completely out the window when someone's suffering from addiction. So, this is when we want to try to gauge if there's any serious problems that we need to address. Does the patient seem to be able to communicate clearly? Do they know who they are, where they are, and why they're there? I've seen people under the influence of substances where they can't answer those questions. I had a guy look around my office one time and he said, I don't know where in the blank I am, and I don't know who in the F you are. Hey, that's just how it is sometimes. They get very confused and disoriented, and you have to use your judgment and your experience and what you learned thus far to try to gauge if you think they're safe. If that person appears unwell to the point where you think they might need a physician to check on them, check their blood pressure, yada, 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 you're going to try to convince them to go to the ER. And if they don't want to go to the ER, then you need to explain to them that they need that medical clearance. And a lot of times, if you phrase it that way, we just need you to get medical clearance, they'll go and get a physical or whatever. And if the hospital decides they need to keep them, then they'll keep them. But if not, you're going to click no. And, you'll type something here. The patient, we'll say patient denied physical health complications. Something short and sweet like that, states that the client says that they're feeling fine. Now, then we're going to go down here for acute psychiatric care needs, and it's the same thing. We're looking at mental health as opposed to physical health. So we're going to ask that same question. We're going to say, hey, we talked about your physical health. Let's talk about your mental health and your psychiatric history a little bit here. Have you got anything going on right now that feels like an emergency? Have you thought about harming yourself any today? I like to approach this a little. Every assessment I've ever seen wants to straight up bluntly say, have you thought about killing yourself? I try to word that a little softer before I directly ask that. Our admission forms have a suicide screen sort of built into them, so we can approach that a little softer. I highly recommend before you get to this section, you do some kind of screener like that allows you a softer transition. I use the PHQ-9. It's a standalone thing on itself. I can go over that if anybody feels like that's necessary. But the PHQ-9 is just a 9-question screener for depression. And the last question asks about if you've had thoughts about harming yourself or any suicidal ideation. It lets you screen that out just a little softer. I recommend highly doing that, because if you bluntly say, hey, you think about killing yourself? That's a little insensitive for one, but also they may not give you a straight sort of answer. So we're looking at rating that too. And we'll say for this person, they denied all that stuff, so we're going to click no on that. I don't like this one. It's hard to get my X's right where they go. And if you got see, this one I'm saying, like I've got another little box here that I don't need. I need this one to move up. There we go. I guess if I took my time and clicked it a little better, I might. One of the things that I don't like about this version, it says, if yes to question 7, ask these. Well, I don't have to click them, but I also don't like to leave them blank. So I like to go ahead and put an X in there. You don't have to, I don't guess, but it's just shows whoever's reading that you actually did think about them. And once again, if there's something that maybe they did admit to, but you don't think it's imminent risk of harm, that's the key right there, that imminent risk of harm to themselves or to others. If you don't feel like there's any imminent risk, you're going to click no. Now, it may ask it 100 more times. You may bring it up 100 more times. But we'll say for this client, the client reported past, let's say PTSD and major depressive disorder, that they saw I hit the caps lock, saw a therapist for in the past. That shows that I did ask like a little bit of mental health, like history. Now, they may not have any kind of history, and you'll get a feel for that, but you want a little blurb here that shows that you did screen for it. We're not leaving any blanks. Now we get to the fun part right here, where we're going to dive straight into substance use. And what we're looking for is just sort of a screener to give us an idea of how serious it is. So we're going through a fentanyl epidemic here in southeastern Kentucky. So let's imagine a fentanyl user comes in and they're court ordered, like we said, to IOP up there earlier, or drug court or whatever. We want to know how long ago it was that they used this fentanyl. So we're going to ask that. We're going to be like, hey, I know you spent some time in jail, so let's count that time too. But when did you last use that stuff? How long ago was that? and they might have been in jail for 90 days, and they might say, well, my arrest was for fentanyl use. So you can either, it's got hours, days, weeks, and months. I don't ever break it down to hours unless it's like urgent or something, because once again, I'm outpatient. But if you were at a rehab or something, it may be hours, it may be yesterday. So you're looking at a really short time frame. When you get up to months, I like to either put 90 days, but we're going to say we can put 3 months. And it don't really have a handy dandy like checkoff thing, so I just type a capital O and make it a little bit bigger so I can drag that right over that month thing, and then anybody can see that that is 3 months. Now, we're going to imagine a really serious amount of use, so we're going to say they were using 1 gram a day. That seems to be where the high use is. We're going to put 1 gram there, and then we're going to put that there all the way up to IV use. IV use means, of course, they're injecting it. We'll make this one sort of straightforward, and we're just going to leave it at that. Now, a lot of times with fentanyl in southeastern Kentucky, they're also using methamphetamine. So you would check the stimulants box here, and you would do the same thing for methamphetamine and find out how much that is, and if they were IV using that too. Good chances if they're IV using fentanyl and they're also using methamphetamine that they were IV using methamphetamine too. There's a lot of other ways with meth that they do use it. They parachute it. That's where they put it in a little napkin or coffee filter or some kind of little wrapping paper. And when they get done wrapping it up, it kind of looks like a parachute, and then they'll swallow that. That gives them a more delayed reaction. Sometimes they grind it up and snort it. That's a really common way that's used also. And most of the time it's either going to be smoking it or IV use. And IV use is sort of it's not a diagnostic per se, but it will tell you, like just as a litmus test, I guess, if it's going to be a severe drug use when we get down to that diagnostic criteria, that kind of gives you a heads up that, yeah, it's probably going to be severe on your diagnostic. But you're going to go through sort of all the substances. If you want to address tobacco and nicotine too, you can. I kind of feel like that's the least of our worries. I know different jobs in other places are really adamant to address tobacco use as well. I feel like if we've got somebody about to overdose on 1 gram of fentanyl a day, I'm not going to harp on them about their cigarettes. We'll put that fire out or defer that to their regular doctor or whoever. I could care less if they smoke. But I do like to come here and type up a comment. I may put the client admitted to using about 1 gram a day of fentanyl, and that they have been injecting it for we'll say for the past 6 months of use. Now, I like to say that because on some of the other assessments, on some of the other assessments that I do, it wants to know when they started using. And that's one of the things that we can use to sort of help build up our, case about how severe this drug use is too. So we might ask that too, how long they've been using it. Now, after hours monitoring is a really important thing. We like to discuss that. We need those supports right out of the gate to be established. But we also want to know what they have naturally at intake. So we might ask, is there anybody reliable who kind of helps take care of you outside of treatment hours? Like, all your friends aren't addicts, are they? Like, you're not around just one person right after the other that can't help you, right? Because, you're here for treatment. Are you going to be okay tonight? Do you need someone to attend to your medical needs? Like, do you need somebody to help you make appointments? Like, where are you? Usually with IOP or drug court, they're really highly motivated. they want to get out of jail and they've got a lot of energy and they can kind of do it on their own. But it's so helpful if they've got a parent that still talks to them, that'll kind of check on them, a boyfriend or a girlfriend or a spouse even, or kids, just someone who will check in on them outside of the treatment hours. Now, if they don't, that's okay. We can plan on peer support or someone else, case management maybe, a behavioral health care coordinator, someone like that that can help us later. But either way, we're going to check that. We'll put the client has a, we'll say this one has a girlfriend who is sober and checks on him regularly. It could be anything like that. I'm just thinking about what I've seen reported. So this could be anything. It could be a female client. It could be LGBT clients, and they could say, I got a girlfriend who checks on her regularly. Just whatever it may be. I'm not trying to be generic here. I'm just saying, if they have someone who can check on them, we want to know that. And if they don't, we want to note that as well. And this is what's good about the ASAM, is it helps us think about that. So when we get to the end of Dimension 1, based on our observations, is the patient's report of recent substance use. Do we think they're intoxicated? Are they in withdrawal? Are they going in withdrawal? Where are they? And if we know they've been in jail, we could say the client has been in jail for the last 90 days, and the risk of withdrawal is, we don't got space, so we'll say minimal. Okay, there we go. Oh, that's unfortunate how it does that. There we go. That looks a little better. So we'll say that, and maybe we don't have to send them to the hospital. So if no, we're going to send them. We're going to go to addiction needs sort of immediately, and if yes, we're going to continue on to intoxication. So we're going to say this one is a no, but I'm still going to kind of talk about these. So we'll say, are you feeling the effects of substances right now? And I don't see it right here. I still like to answer these. So we're going to say no. And are you experiencing withdrawal, or do you think you will soon? No, because this one's been in jail. How uncomfortable would your withdrawal symptoms likely become without treatment? So this is still in the state or the ideal of them being in withdrawal. Now, I like to try to build rapport in that therapeutic alliance as I go. So I might use this little opportunity right here, and that's why I don't skip these, to say, when you was in jail, how bad was that? How bad was that withdrawal? And if it's a no here, we might not even need to answer it, but it gives us a little bit of a mental break to kind of let the client tell us about their journey thus far. And that's what it's about. Treatment is about where they're at and what they need. So we want to know, well, did you ever have to go to the hospital before? Did you need a doctor to help withdraw you? Did you need something for your blood pressure? Did that spike up? And if that's a no, we're still going to type no. And we also want to know if they did go to the hospital, where'd they go to the hospital, and if they ever had any serious symptoms like seizures. We're going to say no here too, because it's fentanyl. Now, I may run a CALS on this person, and if I knew they hadn't been in jail for 90 days, I'm definitely going to run it. I may run it anyway, and they might be lying to me. They might have got a little bump or something in the time they got out of jail to the time they got to my office. So we'll run a CALS, but we'll say we ran a CALS here, and there was no withdrawal, and we're fine. So that's 0 there. Have they received substance use treatment before? It's not always going to be a yes. You will get some people that'll come to you naturally that's never gotten treatment before. And that's where these first sections and dimensions of the ASAM are super important. And that's why I mentioned taking those little chances and opportunities to build that rapport and let them kind of tell you their story. Yeah, it takes a little more time to do your assessment, but if this is the first time they've ever come to treatment, it sets you up. But good chances are, if they're to the point of IOP and drug court, that yeah, they have had treatment before. So we're going to imagine this person that come to saw us, this what I say, Coke Peppermint. We're going to say Mr. Coke Peppermint. Yeah, he's been in treatment before, and we're going to say, well, if yeah, were you unable to complete the treatment due to your cravings or lingering withdrawal symptoms? We're going to say yes here, and we're going to say the client had withdrawal to the point of physical pain that he said he could not manage on his own. Now that's real. The client might also tell you, client stated his mental health, like anxiety, got bad. We'll just say he said that. We'll say he said it. His anxiety got bad, and that's real. I mean, they'll tell you things like that. If you've built your rapport with them, that's what they're going to tell you. And with opioid withdrawal, they're going to go through those flu-like symptoms that we know about. Their legs are going to hurt. They're going to feel like they've got a puke. They're going to feel diarrhea. They're going to have all kinds of problems. But their anxiety might get bad too. They might start kind of feeling some kind of way, especially when those cravings and triggers hit them. And that's where we're stepping in as a counselor. Now, we also want to know, are you taking or have you ever taken medication to help control substance cravings? So, good chance if they're here for fentanyl, that answer is going to be yes. It could be Suboxone. So we might talk to them about Suboxone. They might have been to the methadone clinic, and if that's the case, you're going to type methadone right there. But they could have tried other stuff and it just didn't work. They might have got Withdrawal in the past. Highly doubt it. Withdrawal's not as common, and man, it's I like it myself because it's a heck of a blocker. But chances are you're going to have them say Suboxone or methadone. So we'll say Suboxone for this guy. And I hate that it does that. See how it just kind of made my little thing disappear? Okay, well, it's there, and if I could find the edge of that box, it can make it come back, but I'm just going to type it again. You might, yeah, I typed that right. Did me that way again. Okay, there it is. They might tell you the milligram if you ask. I'm not going to guess at a milligram for Mr. Coke Peppermint here. We're just going to put Suboxone. But I think it's important to use this little chance here to probe a little bit and say, well, how did it work for you? Because, I mean, you're still here. Like, did it help you control those cravings? Did you end up messing up on Suboxone? Like, what happened? And there's a good chance if they were IV using fentanyl, they're going to tell you, well, I tried it, but it didn't really work, and I ended up snorting my Suboxone sometimes too. And if they tell me that, I'm going to go right back up here and put Suboxone here, right under fentanyl, because I get that Suboxone is an MOUD and it's meant to help them, but they can abuse that too. Less common, they will abuse methadone, but it's important for you as a clinician to see if they abuse that buprenorphine. It's possible, but you want to kind of probe and find out. Just because they were on Suboxone don't mean they were doing what they were supposed to with it. And whatever they tell you, you're going to mentally kind of sum that up after you probe around and you spend some time asking questions and getting a feel for it, and you're going to sum up what they say. We'll imagine Mr. Coke here said something like, it didn't work for me because my anxiety got me in my head. And I typed it up like this right here because That's a colloquialism and it's part of the culture, and you're just going to have to get over that as a person and start to learn some of that lingo and get used to it and familiar with it. Um, so, if you remember when we were kind of probing about his mental health earlier, we went ahead and noted that he had PTSD. That's the anxiety he's probably talking about. When he said he got in his head, that's what he's talking about. He's talking about flashbacks. He's talking about nightmares. He's talking about feeling some kind of way. He's talking about triggers. He's talking about cravings. And that's how they word it. They'll say, I got in my head. And what that means is they sat there and ruminated on those things. We can throw out big clinical terms all day long. They may not know what rumination means. So we're going to teach them that at some point, but we want to use, words that are meaningful and make that meaningful connection. So I just go ahead and get used to it and put it on my forms as I go. Get over it. That's what they said. They got in their head. So we're going to want to sum up whether or not they need some kind of medically managed care for that intoxication. Do they need to go back to a Suboxone clinic? Do they need to go back to a methadone clinic? If they're in specialty court may not allow them to do that. If they come in and they're already on Suboxone to drug court, well, how are we going to taper them down? What are we going to do? And, if you remember, I said I was a substance use disorder counselor at the front of this. I can't prescribe that, but what can I do? So for Mr. Coke here, we're going to go ahead and check yes. He does need it. And we're going to say the client is court ordered, but he needs to be tapered off to satisfy the court order for treatment. A referral to a provider will be necessary. May not like that. I know a lot of people will probably be screaming and disagreeing with me. It's not a personal opinion. If they're in drug court and they're court ordered treatment and the judge says, no, you can't have that, and the court says, no, you can't have that, then they can't have it. We just have to be the sound, stable mind that helps them both kind of come to terms with that and develop a plan that they can taper off in a safe manner. The last thing we want them to do is be in a position where they feel like they haven't got any supports. So whether we agree with this or not, that they should be tapered off of it, we have to sum that up in an honest way and be real with them. I don't like to give false hope to anyone. So now we're towards the end of that little section. For Dimension 1, we're going to rate these things. So intoxication, we said he's been in jail. He don't need to go to the hospital. He don't need to go to rehab. He's been in jail. He's not intoxicated. So we also don't want to jump to like intensive outpatient because he's not he's not in a condition where intensive outpatient may be necessary unless he's court ordered just because of intoxication. So he's not intoxicated, so we're going to say there's no specific needs here. We're not going to say any because any would indicate that he had some level of intoxication, and he didn't. So we're going to say no specific needs. Now, withdrawal and associated risks. Fentanyl can stay in one's system for months. He's been in jail 90 days. He denied withdrawals. We did a CALS. We said 0. I don't think it's going to get much worse for him. He don't need to go to the hospital. He don't need to go to rehab right now. And he doesn't need to go to 2.7. And 1 might be arguable here. I don't think we need to eval further other than to just keep checking on him. We're not going to need to do a CALS next week, for example, or 2 days later. So I would think for this guy, no specific needs here either. You could argue 1.7 maybe. He might need outpatient therapy, but I'm kind of on the fence there myself. Now, addiction medication needs. I do think if we've got a guy come in and told us that he was using Suboxone, that he's going to need at least some therapy for that. So we might want to say evaluate that further, but we might want to say, okay, we're going to go ahead and say he needs at least therapy for that. I think we would be safe to say 1.7 here myself, because it just makes sense. He may need somebody to help walk him through that, because he may need those addiction meds. And that may be something you have to advocate at the court for him, even though the court says no. So as of right now, we're going to go ahead and mark that, yeah, he needs to continue, because he's going to need to taper down. So that's Dimension 1 in a nutshell. And what we're doing with Dimension 1, and I'll do the other dimensions if this is well received. But what we're trying to decide here is, do we have a person that we can treat in outpatient and feel confident in our judgment as a clinician to say that this person doesn't have to go to the ER, that they're going to be safe enough in our outpatient treatment setting. And that's what we're trying to figure out. What's some basic referrals for the Dimension 1, where we're looking at current use, recent use, and past withdrawal history. We want to know if the client's going to be able to maintain access to treatment, be compliant with addiction medications like Suboxone, Vivitrol, or Methadone. We might want to think in our head other questions as we do Dimension 1. We may want to think, are they taking their medications correctly? Is there any current signs of intoxication that we missed? Is there any chance of withdrawal that we may have missed? Have they had seizures? Have they had DTs? Have they have complications? And Medicaid in the state of Kentucky likes us for us to rate that. Now, if you notice, there's not really a rating other than this risk rating here. And this risk rating here is telling us what level of care. And we said 1.7 for Mr. Coke here, that would be safe enough. Well, insurance likes it more, I don't know, simple than that. They want you to say no withdrawal, no significant withdrawal potential, mild withdrawal, moderate or high, and kind of rate that on this scale to where, and really that's what you're doing here. It's the same thing here, but if you're sending this to insurance, you might want to type in a little blurb here. I like to do that. Whether other people do or not, that's kind of up to you. Depends on who you're trying to get to pay for the services, I suppose. But you might put, the client is not at immediate risk of withdrawal. We need to think about his Suboxone withdrawal and taper down. He will need a referral, so we rated this as mild, or I'm going to say moderate, because Suboxone's hard to come off of. So we might want to put that there. And, oh man, it did that weird thing again. I'm sorry about that. I don't know how to. There we go. So we may want to put a little blurb like that. I'm all for doing that, because if you send this to Medicaid, then they can at least see that. So hopefully this is helpful for someone. I'm going to upload this, and if you like what I did here to kind of help y'all, you think that was useful, let me know, and I'll start working on Dimension 2 some other time. Yeah, leave comments, suggestions, likes, whatever. Share it with whoever you want to, and let me know what you guys thought about that, and if that was useful or not. And I'll go through Dimension 2 in another video. All right, good mental health. Bye-bye.